facetectomy and then go to Para-UBE. I think that would be a better option. Yeah. Now, ventral facetectomy is my answer to foraminal stenosis. Foraminal stenosis was classified by Lee and others, is usually associated with lateral central canal stenosis. Clinically, it presents with unilateral sciatica or single limb claudication. Bilaterally, if it is there, you can have bilateral limb sciatica and claudication. What is the classification? Grade 0, fat surrounds the nerve circumferentially. Grade 1 is absence of perineal fat in one dimension, either vertically or horizontally. Usually, you see the anterior posterior narrowing of the flavum and the superior inferior narrowing because from disc or osteophytic encroachment or disc loss. In grade 2, you see a perineural fat visualization circumferentially. No fat around the root, but the root is intact. And in grade 3, there is absence of perineal fat visualization, but there is a morphological change. The root appears like a bean. So it's going to undergo a morphological change. These are stock images. They're easily available on the net, and I think all of you understand it. So I won't waste time over here, and I will just jump a little further. Let us talk of the factors. In foraminal canal, you have the anterior factors and you have the posterior factors. What are the anterior factors? You can have a disc bulge, which can be hard, chronic, soft, acute herniation. You can have ossification of the posterior longitudinal ligament, and you can have osteophytes from the vertebral body edge or from even calcification within the disc. Then you have the posterior factors. What is that? That is the caudocranial invagination of the superior articular process. Why? Because the disc has collapsed. This leads to buckling and thickening of the ligamentum flem to जाऊ शकते घरी. And you also have an enlargement, enthesiopathic enlargement of the superior articular process. Now, why do I read the word enlargement? You see, after our skeletal maturity is over, bone doesn't really grow. But like a calcaneal spur, because of the traction of the plantar fascia, same way, if you were to see anatomically, all the deep muscles of the back, what is called as a transversospinalis group. The word transverso means starts from the transverse process. Spinalis means spine. It includes the multifidus, the rotators, that is the short and long rotators, and all of this, and the semispinalis, 4 muscles, and all of them arise from the transverse process tip attached to the superior articular process before going towards the spinous process. So what does it do? It causes traction, osteophytosis, and enlargement of the superior articular process. Now, this causes what? If supposing this hand is here in my arm, it's comfortable. But moment I have osteophytosis and it becomes like a clump, then my nerve root is stretched out over it. I have pain. So therefore, enlargement of the SAP is a reality that needs to be understood. So here you see this is a stock image, nothing great about it, but I taken this image because I love this image in a sense. Supposing I were to come from inside, how much would I come from inside if I were to preserve some of the IAP? I would be able to cut like this, like this, like this, like this. And I would be able to reach here. But what about this SAP hypertrophy, which we spoke about? Nothing I can do about it. Fine. Posterolateral disc, foraminal disc, fine. But what do you do to a far out syndrome disc? Can't reach it. Now, if I were to take an outside corridor, how much of the SAP can I cut? I can't cut the whole SAP. So I can cut a part of it. So I can reach here. I can attach, I can do the paracentral work, foraminal work, and far out syndrome work. But if there were to be a central disc, I may not be able to reach it directly. I'll have to enter here and then try and bite internally. Not a good thing. So I would prefer to then combine two approaches, one posteriorly and one posterolaterally. So depending on where the pathology is and depending on the inclination that you can work with, the sector you can work, that should make you to take an informed choice about your approach. So now these are the textbook things about the advantages and disadvantages. Transforaminal fast, tip of SAP resected, axillary flavum resection can be done. You can do disc decompression, but you cannot solve central stenosis. You cannot solve lateral canal stenosis in a very tight foramen if you try to put in a scope. Now, this is a very interesting study. All transforaminal endoscopists will talk to you about the study of Mirkowitz and Schwartz that says that you can put in a 7 millimeter, 8 millimeter transforaminal endoscope beautifully in the foramen and nothing will happen to the nerve root. Absolute bullshit. Let's put it that way. You are going to cause pressure on the root. That pressure on the root is like a tourniquet on the root. You need to relieve it intermittently, otherwise your patient will have root dysesthesia. The foramen is not classically typically round, and you are not dealing with normal foramens. You are dealing with abnormal foramens. And the worst part, now comes the worst part. If you were to see, there was a beautiful study by some Asian doctors, and this article was published in the European Spine Journal in May 2002, and they did a quantitative three-dimensional anatomy essay in Singaporean patients, which included Indians from Tamils, Chinese, and the local Malay people. And they found that in normal people, my height, 5 feet, 5 inches, 6 inches, 5'7", our foramens compared to the Caucasian foramens, people who are Danish and people who are Swedish and people who are from the African stock, they're huge, they're giant, they're bigger foramens. The Asian and semi-Asian group of people, our Arab friends, the foramens were 30% smaller. So think of the disadvantage. So therefore, I've written here, difficult in a very tight foramen, high incidence of root dysesthesias, even foot drops, has to be done bilaterally in case of both foramen involvement. Monoportal or UBE ventral facetectomy. Advantages, yes, tip of SAP easily resected. Associated disc decompression can be done, yes. Can resolve central canal stenosis, flaval pathologies. You have a flaval cyst, you have a lateral recess stenosis without cutting too much of the SAP. You can very easily resolve it. It's very easy to do in a tight foramen because you're never actually directly entering the foramen. You are above the foramen. You can see the exiting nerve root. You can go ventral to the nerve root. You can go dorsal to the nerve root, which is what transforaminal surgeons can't do. You can bilaterally reach both foramens through one set of incisions, but its disadvantage, yes, definitely more time consumed. Now, let us just talk of monoportal and biportal endoscopic ventral facetectomy. What are the types of ventral facetectomy? What do you mean by ventral facetectomy? This is the facet. I want to cut the facet from here, not from above, from below. So it's ventral facetectomy. So the types are interlaminar, contralateral, endoscopic, laminoforaminotomy, where I go across the dura into the opposite foramen, cut the superior articular process over there, and open up the space for the nerve root. I can enter down after I do my central decompression. I can go down into my own lateral recess, put my scope there, turn around and have a look at my own foramen from inside, cut it and clean it up. So that's ipsilateral switching portal technique. And finally, like I explained to you in that stock image before, if I feel that I have a far out syndrome, if I feel that I have a far out osteophyte, and I need to resect these things, then I need to do a para-UBE. Or you can do a combination of all of the above in one patient. You can do an ICLF, you can go inside, do an ipsilateral cutting, and then shift your scope a little outside and go into a para-UBE. So you can work whichever way you want, mix and match. There's no two-piece suit over here. Now, when we are dealing with endoscopy, now like I've shown you that this is an ICLF, I can cut this SAP tip, but I can't touch this. If I'm doing a para-UBE from here, I can cut this outside zone, I can't cut this. You can, and we do, but there is a technique to it. So, but to understand it, we call it as the hidden zone. Now, when we are doing with this over the top, cutting this is enough. You don't need to touch this. But when you're coming from out, you need to not only cut this, you need to cut this hidden zone part also, because the SAP is literally like a J-shaped structure. It is an outside vertical wall in which the IAP is abutting, and it is sitting on this lateral recess over here. So not only do you cut the outer part, but you need to cut the inner part of the J, which is what I've shown over here. Now see this image. We spoke about approaches in Para-UBE, in ICLF, in undercutting. If I were to have a calcification in a disc which is starting from paracentral area, covering the foraminal zone, and then going in the far outside zone, what is the approach I should use? Obviously, I will use an approach of a para-UBE because that allows me to cut from here, go here, and bring down the nerve root. But if this ossification of this were to continue here, if it were to continue here, then obviously I need to take an approach from here, shift the dural tube a little bit, undercut this hard disc over here, cut part of it here, then come out and do a para-UBE and remove this to bring down the nerve root. Why is it important to bring down the nerve root? Because if you don't change the floor morphometry of the nerve root and the nerve root remains elevated, post-operatively, your patient is going to complain of pain, 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 and pain. And you are going to be a worried surgeon, wondering what the hell have you done? You did a good surgery, patient not happy. The reason is 60% of all failed spine surgeries come from the foraminal zone, not understanding the foraminal zone and not taking a proper rational approach. Now you see this is an example of an ICLF. I'm playing a video. I've gone over the dura. I've gone into the opposite foramen. You can see my laminar edge here. You can see how much I've burred underneath. I made a tunnel. I'm going across and cranially into the opposite foramen, decompressing the opposite foramen, removing the phlegm on the exiting nerve root over there. Then I will identify my superior articular process, which I see is white over here. And then I will plan my osteotomy. So now I'm bringing in a J-shaped hockey stick osteotome, and which is part of the chisel set. And then now you see how I'm banging it across until this black hole will enter inside. Now you must be careful in not overcutting, because if you take out too big a piece, you won't be able to pull it in. If you cut too small a piece, you are not going to get the relief you want. So you need to judge properly. And then slowly, now I'm tamping in my J-shaped osteotome, and you can see how I'm fracturing the tip of the superior articular process. And then gradually shifting it until it shifts into the canal. So that is the movement that you have to understand and learn. And slowly, the whole piece will come into the canal. You need to slip on it, glide on it, and then pull it in. You don't need a very sharp osteotome. It has to be pretty blunt, to be very honest. But you see how uglily I fractured it. If it was sharp, it would have been cut properly. It's not sharp, so it's fractured ugly in a manner. But it's nice. And here I'm pulling in the whole tip of the superior articular process. And you see how large it is. Okay, so that was the hidden part of it. Then doesn't come out in one piece, so I need to go back in and get it out. Slowly, it's out. So now my whole foraminal canal is open over here. Below here is a discal surface. Cut SAP, IAP is intact. Rest of the SAP is intact. Rest of the opposite joint is intact. Dura is below. We've done a pretty decent job. We're cleaning up over here. Slowly checking out on the discal surface. You can see the discal surface below us. And you can see the full root over there. Can you see that root? I'm stretching out the root to show it to you. So you can even remove this. Afterwards, we remove this disc bulge that was bulging out over here. But that's a different story, so that's not part of this video. But what I'm trying to say is you can work on both sides of the neural tube comfortably, proper exposure, doing what you can, others can't imagine doing, retaining the IAP because you're going angularly underneath the IAP, cutting the SAP and seeing the whole exiting nerve root and the axilla below you. Otherwise, you would have to cut this bone to reach this axilla. That is the great advantage of UB spine surgery, that you can do a lot of tunneling, keeping bone stock intact. Hi, dear friends, and welcome. This is ipsilateral undercutting. Here you can see this foramen, and you can see how tight this foramen is. It's a redo spine surgery, and you can see it doesn't look so bad. But when I go down, I can see that there is a nice hard disc over here. I can see the traversing root. I can see the bulge. And now I've gone into my own foramen and I'm cutting underneath into my own foramen. And you can see the exiting root and its veins. You can see the facetal capsule being cut by me. You can see the foraminal ligaments over there. This is cutting of the superior articular process, the foraminal ligaments, the flavum that is there. The facetal capsule is white. And you can see how nicely I'm freeing up the entire nerve root. So you can expose the entire exiting nerve root. I'm over the dura, but now I'm ipsilateral. I've gone to the opposite side of the patient and I've gone on my own side, which had actually gone from above. This is the dura. And this is cutting underneath the IAP, SAP and freeing my own foramen. So we will do a little more skipping here. And you can see how nicely the foramen gradually opens up. To the point that you have completely freed the exiting nerve root. So that is the advantage of doing an ipsilateral shift and undercutting surgery. Keeping the IAP, SAP by and large intact. You can see the laminar surface. You can see your own side. You can see that you are over the dura on your own side. So this is an ipsilateral. This is an ipsilateral undercutting surgery. We have done a CT scan. 1 minute. Right, as I've done, see the adequate resection of this. Can you see that I've cut the SAP adequately here? There's an immediate post-operative CT scan of the patient. Immediate post-op. Within minutes of the surgery, we have done this. And SAP yet more than 50% of the. You can even see the air bubble inside that is still retained some air over there. You can see the muscle mass is nice. You can see some little air that pockets that that gets reabsorbed. But I'm trying to show you that we have done a joint is retained immediately. You can see a small air bubble over there. Thank you so much for your kind. Let us go to the next video. This is again a redo spine surgery. My own patient comes back to me with secondary foraminal stenosis. Disc bulge here. There's no root really visualized over there. Let us see what we have done here. We have done a Para-UBE. We've come from outside. This is the IAP-SAP junction. You can see the superior articular process over here. You can see the corner of the IAP and the transverse process. I'm entering the foramen from here. I'm cutting into the foramen. I'm freeing up the root Secondarily, you can see fibrotic tags on the root. I'm burring away the SAP and then trying to create more space for the root to come out. You can see the root is below over here with the tags on it. I'm burring away the SAP bone and subsequently assessing everything and then doing an osteotomy. So now I'm doing an osteotomy and I'm flipping the fragment out into the foramen. What you saw in ICLF was into the canal. This is outside the body. It's like a Wilson's approach. And there's a huge, gigantic piece over here. So we get that piece out by holding it with a kerosene and pulling it out slowly with a jerk. It morcellates. I have to use a foraminotome to finally deliver it. And at the end of the whole thing, you can see nicely an opened up foramen, tags of the nerve root, and the discal surface below. The white surface is the discal surface below. So part of the SAP cut, the exiting nerve root completely freed. So the patient, and that is the disc where you see this moving is the disc. So we have done a nice job in decompressing. So this is a Para-UBE. So I showed you 3 videos that deal with ventral facetectomy. Having completed that talk, we will go on to the next. And we will now talk more about Para-UBE. Para-UBE is descending on the side of the vertebral column to deal with pathologies that cannot be addressed from within the central canal satisfactorily. So what are they? They are the extraforaminal pathologies, extraforaminal disc, a coracotransverse ligament impingement, a Bertolotti syndrome, foraminal canal pathologies, which are anterior foraminal pathologies like a foraminal disc, osteophytes from the vertebral edges, posterior foraminal pathologies such as the caudocranial invaginational superior articular process, primary flaval hypertrophy, secondary flaval hypertrophy due to disc collapse, root fibrosis, redo spine surgeries, and finally up-migrated herniations above the axilla. So there's a whole spectrum of it. Where do you work? You work in this zone. Transverse process, IAP corner, SAP here. Where do you target? You target landing below on the pedicle or on the pars point. So this is the zone of your work. If you were to see in a C-arm, this would appear as a pedicle round, and you're supposed to land here and start stripping and seeing the facet joint and going downwards. Now, I put this image here. It's actually a stock image. It just shows you the segmental artery and it shows you the primary dorsal arterial branch. See, there are 3 branches that come out in the foramen. One is the primary dorsal branch. Then obviously we use the word primary dorsal branch. There has to be a primary ventral branch. The ventral branch supplies the vertebral bodies. The dorsal branch goes into a pedicular branch that supplies the IAP, the SAP, and the base of the spinous process. And that is why, gentlemen, sometimes when you do open spine surgery and you cut the spinous process, you see a spurter coming from there. That is the artery here. Then you have a branch which accompanies the dorsal nerve root. The medial branch of the dorsal nerve root, which comes up and supplies the facet. So you have that branch that accompanies that, and that branch is seen here in this image. Can you see these loop branches? And these branches divide into the superior, middle, and inferior facial artery. So when we are doing an open surgery and we want to put in a pedicular screw, and we cut that capsule and we try to go towards the transverse process, we have huge bleeders coming from there. Now what do? We just char them. We burn them to try and control the bleeding. But that again is coming from this branch. Now comes the third branch, which is the main branch, which a Para-UBE surgeon needs to understand. That is the artery to the root. Now the root has 2 parts, a ventral and a dorsal branch. So you have 2 arteries, a ventral branch and you have a dorsal branch, which supplies the dorsal root. But the dorsal root branch also supplies the DRG. Now the DRG is a big structure. So you have a branch which goes distal to it and a branch which supplies the proximal tip to it. So you have these arterial structures in the foramen. You need to know where each one is. It's written in my book in great detail. Then you're not worried about bleeding. You're not worried about what will happen. Oh my God, vessel will retract into the aorta. Patient will bleed to death. I will need to do embolization. No, you just need to know your anatomy. The portals that you take, you mark the midline. From the transverse process, mid-transverse process line, you come and park yourself over here or dorsally on the lamina below the pedicle. From the lower transverse process midline, again the entry, and again parking over here on the lamina. This was the mid-transverse process line. Now you're triangulated over here. You strip the tissues on the facet joint, and then you start going under the facet joint. You'll be able to see this view. Now, what are the steps in the surgery? You have to identify the facet joint. So that is what we are trying to do over here. You can see that we have identified the facet joint over here. This is the transverse process side. This is the IAP. You can see the flow of the flavum over here. You must limit your descent to 50% of the IAP. Never go down under below the SAP. Avoid that. You never know where your root is shifted. Work on the IAP, make the IAP larger, because after you do this osteotomy, there's a hidden part. We spoke of that hidden part that needs to be cut. Can you see this horizontal part? We are going to fracture this horizontal part of the superior articular process. So you have to plan your osteotomy, cut, fracture the osteotomy, and then when the osteotomy comes out, you will see a beautiful root below. You'll be able to identify the Camben's triangle, the axilla. You can remove paracentral, even a central disc from there. You can see this root besides us, and you can see how calcified hard this disc is. See the calcification in the disc. It's horrible. This is the cut SAP. See the calcified disc, see the traversing root, see the axilla, and see how the Indian knife enters there and how a fragment comes out. So you can do this surgery in a bloodless manner with complete identification of anatomy. Foraminal ligaments were considered to be a myth. If I were to talk to you about, oh, there are foraminal ligaments, there is the CTC ligaments, and there is the intraforaminal ligaments, you'll be looking at my face and wondering, what is this idiot talking? But the fact is that endoscopy shows things to you. So have a look at it. See what I've done. I'm showing you the superior transforaminal ligament. I'm going to strip away the flavum from that ligament. Because in the foramen, the flavum and the ligament, they mix together. So I'm stripping the flavum away. And see, I'm using a 4-number kerrison to cut into this huge foraminal ligament. And after I cut it, after I cut a part of the SAP, and you will be able to see how nicely the nerve root looks free after that. So for a nerve root to be free, freedom from axilla to beyond the superior articular process must be mapped. I think I've already shown this, so I will not play this video again. It was of that huge piece of bone which we needed to remove and morcellate and remove. Now we talk of a far lateral disc. So you see here again a superior articular osteotomy being done. Already the IAP has been partially burred and cut. A huge fragment that is the hidden zone, which we spoke of, the hidden horizontal part. That must be removed. Then the flavum must be removed. And as you can see how beautifully the foraminal canal opens up, how nicely the root is pulsating below you. From there, you can go by the side of the superior articular process. See, I'm going outside the superior articular process. I'm tracing this nerve. Can you see this vessel on the nerve root? This is the artery to the nerve root. Can you see this? Yeah. And that is the disc surface below. We are probing it. It's a far lateral disc outside the superior articular process margin. Okay. And then we go ahead and do a discectomy over there. And you can see our hook below the nerve root outside the vertebral column. So you have removed a far lateral disc from the far out zone. This is so easy with Para-UBE. Now, this patient came to me with an extreme lateral Para-UBE, which I had to do for a reherniation. I don't know why the hell. Maybe it was a pre-existing lateral herniation, which the surgeon could not remove. Whatever be his reasons, I don't understand it. But it was there. I had to come in a very extreme lateral manner to avoid this implantation. And let's enjoy this video. You can see how we have entered the disc from far lateral position. You can see my scope far out. And you can see a lot of fibrosis around this nerve root. Can you see this? This is ventral to the, this is cranial to the root. And you can see his old discectomy. You can see the muck that is lying below this root. You can see the fibrosis on the root. The root is plastered to the superior wall of the foramen. That needs to be released. I'm using an arthroscopic punch to punch away and remove all that mucky material, bony material, spiculated material that is just lying there in the underneath the root. That's the cause of his pain. So we clean it up. Then we come on the root. We have to free this root from here. We find a lot of fibrosis on the root. Slowly, slowly, we start stripping that fibrosis. I want the root to see the root is stuck to the top of the foramen. I want it to be freed. And I want to get into the discs. The axilla is on this side. That was cranial to the root. Now we have to come caudal to the root. So on the root itself, you can see I'm using my plasma. And I'm burning away all this tissue, then putting in my disc punch, finishing the remnant of the discectomy that I needed to do, or maybe the surgeon had left behind. But over here, above here, you still see a band on this root. There's something amiss. You have to be careful. And see, when I tear it, you can see how it tears off, and there's a red vascularized tissue there. So I push my scope deeper. I take an arthroscopic punch and I start cutting out that fibrosis which is on the root. You can see the hole below in the disc. That is the remnant of the old scar tissues. Now, as I remove that, you can start seeing the original annulus. And we are moving towards the axilla, removing all that vascular tissue until you can start seeing the flavum there. So I know that I have gone right till the axilla, freed all this fibrous tissue from around my root. I later put in a fat graft which I had removed from below the skin and use some antifibrotic drugs, steroids over a small period of time to prevent refibrosis. Patient did well. See this patient. Now you tell me, if you were to try and do a transforaminal, I think it would be a tad bit difficulty. Para-PSLD, yes. Para-UBE, yes. Let's play this video. See how I've gone down. I'm going down along the superior corner. And I'm finally freeing this root, going cranial to it, above it, below it, and slowly, slowly, slowly freeing it out. So you can free a nerve root from outside without disturbing the rest of the spine, without rushing to fusion all the time. Fusion is not the answer, gentlemen. Not every time. Motion preservation is important. This is one of my most difficult cases. It's literally like a quiz. Enjoy this view. 70-year-old patient with acute radiculitis in L4, L5 distribution, 1 week onset, EHL, EDL, grade 3 by 5 power, and sensory dysesthesia. See where this is reaching, and now see the next slide. Here you have a chronic, hard calcified foraminal disc. And here you have a soft herniated foraminal disc. So 3, 4, soft herniated, 4, 5, old. Patient has already undergone a discectomy and has a asymmetric collapse. asymmetric collapse leading to stenosis. This level was hard, chronic root irritation, but this caused an adjacent segment disease here, leading to an acute disc herniation above. Patient is 78 years old and she refuses implantation. What would most of you do? I'm sure most of you would do fusion, right? I didn't have that choice. Can you see this guy? Tom Cruise, Mission Impossible. I'm sure you've all seen that movie. So what do we do? And she was the mother of my anesthetist. VVIP patient. So now what do we do? So we do a para-UBE. You can see I've already done the osteotomy of the SAP, but there is no gap. There is zero gap. This is IAP, that is transverse process here. SAP osteotomy done, but the bone is still going deeper and deeper below the transverse process. I can't see the root. I must secure the root. So I start working on the transverse process. I cut part of the transverse process and I finally open up the foraminal canal and I see the root. Now I start opening up the flavum, the root canal. And I can see the tags on the root. The root is free. Now I take salami slicing, slowly keeping on cutting and breaking away the piece of bone that is deep inside the canal. So the superior articular process has invaginated so deep that even after so much of removal, I'm not able to see its tip. So I have to cut more of the IAP corner. I have to go up. Unless I go up, I won't be able to remove it. If I can't remove it, I have not decompressed the root. The old lady is not going to be comfortable with her pain. So finally, we do a further salami slicing, one more piece out. And that appears to be the final piece. Yes. So you can see how deep we have gone. Finally, you can see the hard calcified disc. You can see the axilla traversing root. Little elevated. We had to do a discectomy, partially again, to decompress this thing. But it was such a tight and a horrible case. We'll talk of this case. See this patient. There is a bony stenosis here at L5S1. It's hard. It's bone. What should I do? So again, I do a para-UBE by an alar approach. I land on the sacral ala and I'm burring away the sacral ala to free the coracotransverse and iliolumbar ligament. Then climbing up on the S1 pedicle, cutting the pedicle and the SAP from underneath, and then freeing the entire L5 nerve root. So bony stenosis is relieved. You can see the nerve root. You can see the hard S1 surface over here. And when I retract this surface, when I remove this fat, I see that there is an ossified hard disc over here. So this is the S1 bone. Now I'm climbing up onto the foramen, freeing the traversing root. You can see the vein of the traversing root. You can see the fat on the traversing root. Axillary over here. S1 surface here. And with a dissector, when I pull away the axilla, I only see bone over here. So there's no need for any fusion. Fusion was not her answer. Para-UBE was the answer. And now I'm cutting below the transverse process to go cranial to this root. Free the root from all forms of impingement. So gentlemen, primary bony stenosis of the L5S1 foramen was tackled in this manner. So I hope you enjoyed this little talk on para-UBE. Please tell me when you are tired, so even I will shut off or I will continue. Now we talk of para-UBE for up-migrated discs. I have published on this. And this paper is also coming up in the next issue. So you will enjoy that. But right now you can see this video. Can you see what I've done? This patient had undergone a fusion surgery in the past, adjacent disc disease, up migrated herniation here. But what is the level? The level is a L2 level. We are way up. Now, if I were to go for this fragment here, I would literally cut through the entire lamina and by destabilizing the spine. So what do? I chose to do a direct access to the Camden's triangle, no laminotomy, no flavectomy, dura, and sometimes even roots need not be visualized, and you have minimal loss of blood. Here you can see how I'm confirming my targeting. And finally, after doing a slight osteotomy of the SAP, you can see the traversing nerve root here. You can see, you can't really see the, traversing root. You can see only the exiting root. But I'm going from below the axilla. And out comes the up-migrated fragment. This is the disc over here. We will be seeing that also shortly. But you can see how nicely and beautifully we can remove the multiple fragments that have herniated upwards. And then when I burn away this tissue, I can see the tear. Can you see this discal surface and bone? You can see the interface between bone and discal surface. And this is where this apoptotic tear occurred, driving a herniated fragment upwards. So we are burning away this discal bulge also, shrinking it up, checking whether there is any other further annular rent fragment. I see nothing much, but when I'm probing further, one more fragment again comes out. So nothing is done until it is completely done, but it must be done. And finally, end of surgery, patient comfortable, gone home. Sometimes we have a difficult choice to make. I was doing this live surgery, and this patient had primary foraminal stenosis and an up-migrated fragment. Now, our focus was on the up-migrated fragment. Nobody noticed that this patient had a flaval thickening and a severe foraminal stenosis. If you were to have removed, gone up and removed only the up-migrated fragment through a central approach, not relieved this foraminal stenosis, see how much I'm cutting, so much of flavum I removed. Finally, I'm removing the fragments. Fragments are subligamatously entrapped, up-migrated, but gradually they all come out. You just need to persevere, persist, and slowly remove via Para-UBE. So we killed two birds with one stone. Foraminal stenosis was taken care of. And here you can see how nicely you can reach up, sweep up, keeping the entire lamina intact. Surgery done. Sometimes, and this patient, I want to show this video is because I wanted to see the amount of fibrosis of this root, how tight this root is. There is an up migration. So I had to remove all the up migrated fragments from below the axilla. Then expanding the surgery, managed to put in a cage, nicely fuse this patient. See this patient with a huge up migration over here. See these images. And you can understand what Para-UBE can reach, can achieve without fear, without worries. So easy to do. See this. At L34, that same patient's up migration, there's a lot of fat in the axilla, slowly going by the side of the root, burning out that fat. I can see the vein besides the root, so I know I'm safe. And then using a 60-degree curved hook. A 90-degree hook will not slide up onto the vertebral body. So you need a 60-degree angled hook. It is there in the special UB set designed by me, because where a 90 doesn't work because of bone restriction, the 60 slides in smoothly. So using a 60-degree hook, I'm able to retrieve all the fragments, free up the nerve root, and eventually you can see how many fragments come out. But you can even see the traversing root now. The root has come down. In the previous video, first video, you could not see the traversing root. Here you can see the traversing root. You can see the full axilla. Pre-op pain, post-op pain, usual 6 months follow-up, everything fine. I don't want to go into all those statistics. Thank you so much. So I will conclude this talk. I'm tired. Now let's take the next talk, which I think will be interesting to you guys. UB endoTLIF. The use of the vertebral venous plexus as an anatomical landmark for flavel preserving UB endoTLIF surgery. So what is it? The targeting is by and large steady, standard. You need to be a little lateral at the tip of the transverse process. And you need to target being in the lateral plane for your cage to enter to be in line with the disc. Sorry. And then that will mean that you need an upward shift of the portals so that your cage goes in beautifully. Now what you see here, bone graft packed in, but do you see the neural tube? Nothing. I will be putting in a cage over here with the neural tube intact. I put in a titanium cage, I'm making it horizontal. Graft is locked in place. And then I start doing the flavectomy. So I preserve the flavum. I do not shift the dura at all. Therefore, I'm taking an extreme lateral approach, not the standard approach. Now, what are the advantages? Because the surgery is extra flaval, I have 100% dural protection. No bleeding. Epidural bleeding doesn't trouble me. It complements the rationale of UB being a one-handed surgery. It identifies and secures the exiting nerve root, which is the most crucial element in this surgery, as it is the cause of. It provides a green corridor to identify the disc and placement of a cage without fear of injuring the nerve root. And it has a detethering effect on the axilla and the exiting nerve. But what is this it? I've used this it 1, 2, 3, 4 times. What is the it? The it is the inferior communicating vein that accompanies the exiting nerve root. The traversing vein which accompanies the traversing nerve root. These two veins join the vein that comes from below the axilla. And therefore, they're forming a trijunction of veins, one coming from below the axilla, one accompanying the traversing root, and one following the root out. It is a triumvirate of veins in the floor of the foramen. It is an anatomical persistent finding and is like a green corridor for a UB surgeon, like how we do an organ transplant. The police guides a vehicle which is running at top speed, all signals are stopped, pedestrians are stopped, vehicular traffic is stopped. Why? Because the organ has to reach from one city to the other, either by plane or by vehicle, very fast. It's a green corridor concept. Now you see here, this is an actual epidural venogram. And this was actually done. It was a very standard surgery. Most of you people who are the old school neurosurgeons, you all know that you are actually even dependent on myelogram and venogram to decide your discal surgeries, even stenosis. This is a routine standard anatomical finding. See this vein that is coming from below the axilla. See this vein which accompanies the root. See this vein which accompanies the traversing and then the exiting root. So you have this loop, one joining from here and one coming here and then joining and out. Now, today, on endoscopy, because of fluid pressure, we can see these veins partially filled, flattened out, in proper correlation to the root. So, this is a venographic image which I've highlighted. And see here, vein, root, SAP ledge, inferior pedicle, superior pedicle, lamina cut up to the dural separation zone, flavum kept intact, explore the Campbell's triangle, take a lateral approach, enter from here, put in your cage. The veins will guide you and protect you. The flavum will guide you and protect you. So see this video. I can see the vein below me, and I'm chasing this vein up into the axilla. I'm using this vein as a corridor. It tells me how much of bone to cut, how much of flavum to cut, and then finally I see the traversing root vein. So I know that I have cut all that I need to cut. Below me is the Campbell's triangle. The nerve root, the traversing root, is still 3 millimeters away from this vein. The exiting nerve root is maybe 2 to 3 millimeters away from this vein. So I'm very safe when I'm doing my surgery. See this video. When I push this vein away, you will be able to see this lateral disc bulge. See that. First, I'm using a plasma, cauterizing the veins. There is a vein tethering the root over here because this vein and that vein are communicating. When I cut this vein cluster over here, below this kerison, you will see how the root falls off. Can you see this root falling off? And can you see this disc bulge? So the detethering effect is so important when you cut this venous plexus. It allows you to mobilize a root, which otherwise you are blindly pushing, bleeding, pushing, patchy, gel foam, waiting for the bleeding to stop, ordering 2 extra bottles of blood. But for me, this is beauty. So poison for some is medicine for some, elixir for some. Preparation of the end plates, nicely done. Flavum intact. I shut off the water to show you the bleeding that is coming from the surface of the end plates that have been curated. The cage has been put in, the graft has been put in, and like the previous video, subsequent to all that, the flavectomy and then the fixation. See this patient, old patient of mine, old laminectomy done many 30 years back, comes back. Not good. What did we do? We took a Para-UBE approach, extreme lateral approach, beautifully entered in, put in the cage, did everything, completed it. So see here again, severe lipomatosis in the foramen. Where will the root be? Where will the root be? It's troubling me. Do you think this is the root? No, this is the vein. I know this is the vein. So out it goes. I know my corridor. I can see the triumvirate of veins below. Can you see these 3 veins now? One coming from below the axilla, traversing and exiting. And see how I cut it. Moment I cut it, see how the root shifts. See how beautifully the root shifts. See the severe listhesis. And I'm still able to enter the disc very smoothly and nice. See this. See how badly this root is plastered. See this. And see these vessels that are plastering this root to the discal surface. Unless I cut these, unless I free these, then remove the up-migrated fragment. I've shown this video to you in the past. And then put in a cage and then finish the fixation of this patient. But this plastering to the dural surface, to the discal surface by the veins was so important. See this patient. You can see this listhesis developed over here. Somebody had done facial screw fixation maybe 40 years ago. And this lady's come back to me for a redo. I've removed these screws endoscopically. And then I decide to fuse her, fix her. So I do a para-TLIF. Come from outside. You can see how I've cut away the SAP. But below the SAP, you can see how these veins are plastering this whole nerve root to the discal surface. I have to be very careful in my mobilization of this fragment, otherwise I can easily tear the nerve root. Now, as I go down in the axilla, I can see this vein. Can you see this vein? 1, 2, and 3. Beautiful, you can see the 3 veins. I have to just keep on pushing from here. I know that my nerve roots are safe. I can control my bleeders. I know where my nerve root lies, and I can easily then create the zone for a fusion. And this was, since this facet was fused, I didn't remove this facetal screw. I just took this corridor, put in my cage and locked it up from one side because the other side God has already fused for me. That is one of the reasons why I could not push this cage deeper. No way, I didn't have the chance because there was no expansion over here. Anyway, coming to case 5, there is osteotomy of this SAP shelf and expansion of a safe corridor, again using the tri-vein route. See now, you can see the 3 veins below over here, and you can see how I'm going to cut away this vertical SAP shelf being cut. You can see the 3 veins, and I'm within the veins. And moment I cut this piece and I take it away, you will start seeing these veins filling up with blood. Why? Because the entrapment of the root is being released. You can see that shelf over there. Then you can see how I've cut away these 3 veins, freed it, and then started with my implantation and cage work. Similarly, here I don't see the classical 3 veins, I see a leash of veins. So this is the anatomical variation that I came across, extreme lipomatosis. So always fire your probe towards the superior articular process, but you can see this leash of veins here. You can see the PLL below. You can see the disc surface below. You can see the root. You can see finally everything very nicely. And then finally go ahead with your discectomy and fusion surgery. So this is entering into the disc. So I'll just skip this video because I've shown you enough of this. This is again a different side. You can see that I'm going by the side of the root down below, fracturing. And then again, the same procedure being repeated. So the veins are a persistent anatomical landmark, which you need to understand. They exist there, they're there to guide you. Use them to your advantage. You will be a happier surgeon at the end of this surgery. So I'll just jump this. And you can see that I've torn this vein here, but you can still see how the root is cranial to that. So despite my tearing that vein, I know that my root is still safe. The whole concept is to know where is your enemy. Can you see these 3 veins? See how they're tethering the root. This is coming from below the axilla. This is the cage put in and the fusion surgery done. This is the opposite side decompression. This is the flavectomy that is done post putting in the cage on both sides. Huge. 140 kgs. Failure. Over 3 months, this cage migrated, this screw migrated maybe because of torsion in the rod, fractured the lamina over here, and the cage is lying inside the canal. What do? Go back in, remove the ini, then remove the rod. Finally, remove the cage. This is grabbing the rod to pull it out. This is backing out the screw, going into the screw canal, seeing where it is where, trying to identify the fractured piece of the IAP. You can see the dural surface over here. You can see that this tissue over there, that tissue is the synovium of the facet joint. But as I'm cutting away this synovium tissue, I see the flavum is intact. So where my screw fractured and pushed this piece of bone in, I can see all the synovium and everything, but there is nothing bad there. So that root has not got damaged. Now I'm removing that fractured piece of bone. The fractured lamina has to come out. After the fractured lamina will come out, I'll be able to see the root going around the pedicle. That is important, identifying the root, identifying the cage. So I'm going around, cutting more into the IAP, going around the pedicle, trying to identify the whole root. Can you see this root here? So finally, I have gone around the pedicle. I'm doing a little bit of phlebectomy also, upper side, because now this fractured lamina has come out. So you can see how we are opening up the dural area. Finally, identifying the cage, seeing the entire exiting nerve root. Never remove the cage without seeing the nerve root. Protect the axilla with a thin retractor if need be, and gradually tamp out this cage. Once the cage is out, I'm completing that little hemilaminectomy that I had done by going around the axilla. So you can see the whole root over here. The whole root can be seen. But now comes the shock. After I remove all this, and I come more laterally, I can see all these plastered vessels. The root is not here, the root is this. These are all plastered vessels. And when I remove all this, see what has happened. When my cage went in, I had a further lateral herniation of disc from underneath and behind my cage. See this. As I push the root away, see the disc bulge that was there. Oh my God. So I had a bulge that was beyond and bigger than the bloody cage itself, the cage which has backed out. And this disc was elevating the root. Why should this patient not develop a progressive neurological deficit? So the cause was multiple. Not that the cage itself was causing so much pressure. It was this disc. So now I've realized one thing. The moment you put in the cage, please look beyond the cage towards your side. See whether you have herniated out something below the root. It's vital. This was a very bad experience for me. This is my own patient, and I will not hide anything, because if the world has to learn, then I have to be honest. My experiences, I think, are a little more than others, and I need to share the good and the bad. So finally removing that disc, removing all that fat around the root first. Then remove that disc. And finally, after doing everything, removing that extra discal material, re-implanted a cage, larger cage inside, and then refix the patient. So that was the story of this patient. Extension of fusion had to be done, so one additional scar, because I could not use that pedicle. I had fractured through that pedicle. I had to remove that lamina. I had to expose that whole root from here, and here. So obviously I had to take an extension there, but it was all done endoscopically. So what are the new anatomical considerations? Remaining extra flavel, identifying and cutting around the corner of the superior articular process, establish a safe foraminal corridor, control conservative vertical osteotomy, lead straight to the floor of the foramen, see the complete exiting nerve root, secure it. The trimeter veins is key to the safe exploration green corridor concept. What is trivial for some open spine surgeons is a beacon of hope in difficult cases for an endoscopic surgeon. UB is a one-handed surgery and as such has very different demands. UB offers unmatched safety in difficult cases of T-lift surgery. Plastering of nerve root to the discal surface is a definitive reason for postoperative foot drop injuries. Hence, the entire exiting nerve root must be explored. Because the moment you put in a cage and you gain height, you are stretching that nerve root between its plastered point and the axilla. Two definitively anchored points. You are going to have an neurotomesis or, exontomesis, and a foot drop. So these new anatomical considerations are a must for an UB surgeon to adapt to. I would say even open spine surgeon should adapt to. I hope you have enjoyed this talk. Let us come to the world of redo spine surgeries. Obviously, when you are a spine surgeon and you've been doing endoscopy for 8 and 10 years, you are going to have failures. You're going to have your birds coming back to roost to you. You're going to have other people's problems coming back to you. So redo spine surgery is a whole new world. Learning curve for me too, and learning curve for you, my dear friends. So how do I classify redo spine surgeries? I classify them on the basis of recurrence of pathology, new additional pathology, failure to address the goals of the previous surgery. Let us see what are the guiding principles. The guiding principles are to open the area of reoperation. You must find some normal anatomy, then expand from there. That way you can't go. Either you land on the facet, land on the lamina, find the plane, then go deeper, gradually use a burr. I prefer to use a burr rather than a dissector. Why? Because when I burr away 1 millimeter of bone with a soft diamond tip burr, fine burr, the neural tissues move away by themselves rather than pushing it away with a dissector and having a dural tear. I use new corridors to approach and reach the same pathology or new pathologies, whatever they may be there. See this patient. In this, there was a case of reherniation, and I'd already done a fusion at this level. I'd done a up-migrated disc herniation removal, and patient came back with a reherniation. So I thought I would preserve the motion segment and let me just do a para-UBE discectomy and fine, and patient will be fine. But no, she came back with a massive reherniation above the level of fixation. So again, I find the same corridor, find the SAP border, see all these synovial tissues, then find the discal tissue. You have to identify the tissue differentiation is the issue under scopy. So find out those differences, remove the fragments, but I'm still not happy. So I decided to do a T-lift. So here I burred away the entire IAP, the remnant of the IAP now I'm going to fracture. And this is the SAP outside. So I shelled out the IAP. I'm fracturing the IAP. Sorry, I should be playing it this way. So after I fracture it out, I've now removed the SAP, put in the bone graft, and put in the cage. But like I told you, now I'm in the habit of checking above the cage, below the cage, everywhere, and I find more fragments. Why I was suspicious of it? Because I could not see the movement of the traversing roots and the exiting root. I could not see the flutter in it with the water column. So I knew there was something tight there. So I hook, I probe, and I still get huge pieces coming out right from on the vertebral body. And when the final pieces come out, you can see how the root is pulsating, see how the axilla is pulsating. So now I know everything is free. I had to do a fusion extension on this side by putting in one more cage. Not a good thing, but it had to be done. Now see this old patient of mine. He comes back to me after 20 years of my doing a P-lift surgery. He's fused posteriorly. Anteriorly nothing. But posteriorly he's got solid fusion and foraminal stenosis. What the hell should I do? So fine. I say, let me go back to the same old path, move the dura away, find the nerve root, undercut the foramen because it's a fused foramen. I can definitely undercut and free the nerve root. So here you see nothing there, fibrosis. And here you can see that I moved the dural surface away. I'm going into the nerve root canal. I'm traversing full nerve root. I'm freeing. Slowly, 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 I'm separating it out. I can see the discal surface below me now. And finally, I have now made my camera a little horizontal to show you the fat on the exiting nerve root. Nerve root completely free, and I'm going to put in a probe over there to show you that I have completely freed the nerve root, retaining most of the facet. It was fused. Problem solved. Patient didn't need anything more. See this patient of mine. failure of my surgery. I have a spondylodiscitis in this case. What should I do? So I say, okay, again a re-down migration, again a fragment over there, abscess over there. So I go back in, I do a para-UBE. You can see that I've removed part of the IAP from above. I'm fracturing through the lamina now. I'm cutting away the bone. I'm exposing the dural surface. I'm going down for the down migrated fragment again. I've changed my portals. My scope is in my other hand now, so that I'm inclined to go down on the vertebral body. And I can peacefully go down there, remove all the dirty, mucky tissue, burn everything over there. You can see this depth at which I've reached. This is the advantage of UB. Preparation of the end plates. Doing an opposite side contralateral decompression, opposite lateral recess relief. Making sure this time the patient must do well. Putting in a peak cage because it is least reactive, less biofilm formation. We got a positive sample. We were able to give good antibiotics, properly placed cage deep inside. Our patient did quite well. Now, guys, see this patient. And I am going to ask you this. I'm going to knock you off your sleep. Some of you are pretty sleepy now. See the 64-year-old female. She had a wide laminectomy done 10 years back. 10 years back. Now she comes to me with sciatic pain and numbness in the left leg. Since last 2 years, and she actually crawls into my room. She's not even able to stand straight. No backache. Obviously, you can see the fusion mass over here anteriorly, huge. What to do in this patient? So I say, let's do a CT scan. Let's do an MRI. I'll pause the MRI. You can see the foramen is open. Fusion has occurred. Foramen is open. There is no huge harm, this bulge, nothing there. There's no pathology there. What the hell, man? What is wrong with this guy? What should I do for him? And it's left-sided, and you can see that the left-sided foramen is quite open. There's nothing wrong on the left in the MRI. So now what to do? So let's do a CT. CT again shows me an open foramen and a huge fusion mass in front. And you see here, left foramen open. Nothing there. As a matter of fact, super wide laminectomy, which caused instability, which went into fusion 10 years ago. And now she's come to me with back pain. Sciatic pain. You can see the fusion everywhere. So what do? I do a para-UBE. And when I do the para-UBE, you can see this white calcified huge ligament sitting in the foramen. This is the corporotransverse ligament, the superior corporotransverse ligament, which is coming from the transverse process above to the ala below. As I burr away the ala, this ligament tears away, goes away. Then I climb up on the S1 pedicle and I see there is a lot of fibrosis there. You can see the dural surface here. So I start to tear out the fibrosis towards the pedicle. And I go towards the pedicle because I want to shift the nerve root upwards. So as I shift the nerve root upwards, I see the fusion below. So what was her problem? A huge white calcified corporotransverse ligament crushing the nerve root. Fibrosis of the nerve root, axilla going and literally gripping the S1 pedicle. Freeing all this, freed her of her pain. So sometimes you need to explore new corridors. It shows you something that was missed or maybe a new pathology. The laws of cage attraction, I've kept it in pink. It should be actually laws of attraction. Here you've written laws of cage extraction. You must identify and land on normal tissue. You must create a safe delivery corridor. Traversing, exiting route must be visualized. Extraction must be visualized at all times because you don't know what is in that damn hole in the cage. Is there a hard fibrous band? Is that band communicating? Is it joined with the root from below? You suddenly pull it and you have a root tearing out. Don't want all that. So what do? Let us have a look at this patient. This cage is completely backed out. It's lying outside. But you can see that the patient already started forming a fusion mass in front. She's already 7 months old. So what do? I triangulate here on the remnant of the lamina. After triangulating on the remnant of the lamina, I try and identify the cage inside the facetal corridor. Clean up the cage from inside, outside, so that I can get a grip on it. But I must see the dura, I must see the root. So I start removing the rest of the lamina. And then I start cutting around that cage in the direction of the exiting nerve root. But the kerison can't go further than this. So what to do? I can see the dura, but I can't see the exiting nerve root. So I start using an osteotome, cutting out the rest of the IAP, which is hugging the cage. And slowly remove these fragments so that I can visualize the exiting nerve root. I can see the fibrous band within this, but it is not communicating with the root. And I finally have the cage out with the root intact, axilla intact, no dural tear, no root injury, patient doing well. See this patient. This is the old, like we mentioned before, I used to do facet sparing transcambin fusion through a transforaminal scope. Fused, but there was subsidence. And now patient comes, cage coming in from the left, and patient having a sciatica in the right. Why? Because this cage kept this foramen a little open, but this side the maybe collapsed. I don't know what happened, but mess. Let us see what to do. So this time, since it was a transcambin cage, the posterior lamina, facets, everything was intact. So I go in on the right side. Again, I remove the ini. Then I remove the rod through the same hole. Push it out to the same hole through which the pedicular screw rod was inserted. Why make a separate hole? Grab the rod, push it out below the skin. See it coming out here through the same old scar. Out comes the rod. And then you see this. I'll pause here. Superior edge of inferior lamina. Facetal edge. Window that is not even 2 to 3 millimeters across. See the amount of stenosis. Now, I had done this fusion on the basis of what? On the basis of Olive surgery. That if I put in a large cage, if I fix posteriorly, the flaval hypertrophy will disappear. But it didn't happen. Somehow it didn't happen in this patient. So now I need to do the central stenosis release. I need to do the foraminal release. And I'm doing an en bloc flavectomy over here because in between we had that, stupid en bloc flavectomy challenge. And I don't believe in it and I don't advocate it anymore. Some people do, but that's their personal choice. No comments on that. But anyway, here I've done an en bloc flavectomy, gone down in the opposite lateral recess, release the opposite lateral recess. You can see how nicely we are going towards the foramen on the opposite side, undercutting. On our side now, you can see I'm on the opposite side of the patient and I'm watching the opposite monitor. The monitor is just behind me. So I've crossed over to the opposite side and I'm seeing my root going out. Ipsilateral undercutting and release of this root. Making sure that little fat, whatever is there, let it remain. Don't want refibrosis occurring. This helped the patient. She did very well. Thank you, gentlemen. Sometimes we come across secondary foramens. This patient was not by me. Some surgeon had fixed this patient and this patient went over an autofusion. No cage, but autofusion. Let us see what I did over here. You can see the fibrosis around this root. So I decided that I need to explore it. I've shown this actually video to you, so I'll jump this. And this was the end of it. I've already showed this to you, so I want to go back to it again. See this patient, very nice case. Recurrence of a pathology. You can see the old scars, old track. This bulge here, foraminal stenosis here, little facetal fluid collection, SAP going right up, a band of tissue over here, black cartilaginous, root totally deformed, no proper root seen, severe foraminal stenosis. What do? I redo with a new corridor 3 years post the primary discectomy. So I'm on the facet, I'm stripping on the facet, and now I will be starting putting in my scope, and I'm doing a Para-UBE. I can see the SAP here, I can see the IAP here. That previous discectomy and undercutting of the foramen, you can see the tags of tissue on this root, and you can see the vascularization of these tags. So I know my root is somewhere here. It's scary for me to push it further. So I start cutting into the IAP, transverse process corner, and I find old flavum there. See, finding some old actual anatomical tissue made my job so easy. So now let's start and explore further. We remove all that fibrous material, and you can see this root here. See all this fibrous synovium which has grown on the nerve root. Source of pain, inflammation. It's under water pressure, so it's not bleeding so badly, otherwise it bleed terribly. So finally, we are exploring this root. Nicely, we've exposed the root. We are doing the osteotomy. We are going down onto the discal surface, gentlemen. You can see how nicely we have identified the root, the discal surface, but I'm not happy. I want to see the traversing root. So now I'm using a dissector and I'm separating the PLL from the traversing nerve root. It's still badly stuck, so I'm using an arthroscopic punch to go there and bite out this PLL. Can you see that? So it's a PLL pathology, plastering of the PLL, tightening of the traversing root, remnant discal material, large fragments over there, recurrence of herniation, all being tackled. And finally, again using a 60-degree hook to sweep and separate the traversing root from the PLL. You can actually see how we have shifted the dura away from the PLL surface. See? And that in the corner from where the traversing root is going out. You can see the axilla beautifully, you can see the traversing root beautifully, and you can see how we have removed the discal material. Let us hope this patient does well. We have gone on to the root, we have gone and exposed the entire root, the axilla, everything very, very beautifully. So what is the take-home message, gentlemen? Identify the exact pathology. Use all modalities. Try and be as least traumatic, fiability and tissue identification. See, you feel, oh my God, this is dura. No, this is synovium. You have to identify the tissue. So you have to be comfortable with tissue identification. You have to decide between the new corridor and revisiting the same or both new corridors. Fine burring of 1 millimeter of bone rather than resecting tissue causes auto separation of the neural elements very easily. Dural tears in endoscopy for redo surgeries for me has been a myth. I've done a few hundred of them now, my own and from others, wherever the sources of patients coming seeking relief. But redo surgeries, I've had 0 dural tears. So for me, it's a myth. Post-operative, an anti-fibrosis protocol blocking TNF beta blockers with the use of pirfenam easily available, some local, steroid deposition of steroid, fat around the root, do what you must, and very, very early mobilization and nerve glide stretch exercises 50, 60, 100 times a day to make sure that post-operative, again, fibrosis doesn't happen in a severity. So that would be my take-home messages, gentlemen. I hope you have enjoyed this talk. The last one talk remaining. I hope you all have the courage for it. It's a very short talk. And let's go here. And what is happening? It should open up fully. PLL and its role in the spine. See the PLL. This is a classical stock image on the internet. But what do you see here? Adhesion to the midline. And then it becomes like a kite attaching to the posterior lateral downward corner of the disc. What does that mean? It means that there is an escape zone for sequestration of a disc. That is why upward migrated discs are never under the PLL. They are free floating fragments. But if a downward migration were to occur, it will always be subligamentous in nature. I showed you one video of an up migration that was subligamentous. I showed you a dual pathology video, remember? Foraminal stenosis. So, strange, but in general, an up migrated fragment is usually free, isolated, not subligamentous because of this escape zone. There are papers that have actually measured this escape zone. You can read it up. I don't want it to be part of the talk. Okay. But the more important thing that it is the origin of the meningo-PLL ligaments or Foraminal bands. Now what happens? Many times I'm asked this silly question, okay, doc, disc is on the left, right. Why is the patient having a left leg pain? I'm sure that has come to your minds also. The reason for that is that this PLL, which is attached to the midline, and these meningoflaval ligaments, sometimes because of an odd placed herniation of the disc material on one side, causes a stretch and a pain onto the opposite side. So you have a disc on the right, pain on the left. It doesn't mean that you go and do the surgery from the left, do it from the right only. Removal of the proper discal material, the stretch and pull on the meningoflaval ligament will disappear, patient's pain will be relieved. So understanding PLL pathology, the fact that it carries C fibers, it is a source of pain, that it is supplied by the sinovertebral nerve, it needs to be looked at in greater detail. Now, this is one thing that is as a concept, just somehow is not existing amongst us. We are so, attracted by that orgasmic moment. Okay, I got the fragment. Huge fragment came out. Yeah, I'm happy. You don't look at the other pathologies. And then you wonder why your patient is not happy. So, what happened here? Sorry, I should be playing it. I'm not playing it. Okay. So now see this video. What do you see here? Can you see the cyst over here? Can you see the cyst? This cyst is in the PLL, gentlemen. See this. As I separate out the PLL, can you see this mass here? The disc is below. It's stuck to the dura. It's stuck to the PLL. It's a huge mass. When I try to tear it out, when I try to grab and tear it out, it breaks. It literally breaks, and there are whirls of clot in it. See how it breaks. I try to catch it. I thought I'll be able to grab it and pull it out. It'll come out in one piece. It didn't happen. You can see the dural edge over there. And you can see how this tissue looks. See the whirls of tissue in it. Repeated bleeding within it. Bands within it. And finally, we managed to remove it completely. And you can see the rent in the annulus. And the rest of the PLL fibers covering the disc annulus PLL fibers. So what I showed you in anatomy is what you can actually see in UB. This kind of visualization of pathology is difficult for an open spine surgeon in the presence of so much of blood oozing over there. Now that doesn't ooze in UB. You need to be meticulous and you can see things beautifully. See this patient. Small herniation of disc, but what is this here? This is vascularized thickened bands of the PLL, crushing this nerve root here. Now let's play this video and you'll be able to see what I'm showing. So sometimes we just assume things and we're not focused on things. And see, you just see this video and you'll realize when I'm saying what PLL pathology means. Targeting, going in. Going into the right corner, this is going underneath the dura to check for any other free fragments. See this? Now this is the root here. See these bands. See this band below this. Can you see this thickened band? Oh, what did I do? Sorry. See this thickened band below the nerve root in the axilla. So what do? I say, okay, this must go. These bands must go. So we say, come on, let's burn them, let's cut them, let's clean them out. See how this PLL has thickened. And see how I have to cut it. It takes time to cut it. Slowly, slowly I cut through it using a plasma right in the axilla. And then finally the discal surface and the bone surface and everything becomes clear. Now there is no vascular pathology there. There is still some underneath the root here. But major part of this band which was troubling, elevating this root, causing crush on the root is gone. Now I'm going lateral to the root. I'm mobilizing the root inwards slowly. And I'm trying to separate out this tissue. Can you see this? See its vascularity. See how this tissue is, this PLL tissue over here is stuck to the root. Slowly separating it out, mobilizing the root. Again, burning, cleaning, cutting, all the usual muck work has to be done. You can see the discal surface below. And you can see how the plastering relieves the root. And eventually, nothing below the root, everything neat and clean. See this video, gentlemen. A subligamentous herniation. We have cut the PLL. And part of PLL fibers and the fragment are now being pulled out. And finally, I am looking below the dural surface. I feel it's adherent. I need to strip it. So I start stripping it. And when I strip it, you see something that is going to come up. You'll be shocked. I'm waiting for the bleeding to clear out. Okay. And then finally, I cut this PLL band. PLL band. And you'll see how the traversing root is now going to come down. It's going to float down. See this mass. And when we cut this mass out, see the cavitation that it causes. And see how the traversing root is beginning to come down. See the rent in small hole here, discal fragment came out. Try not to increase that rent. And see this band. See how this thick. You feel this is you feel that I've caught the root and I'm pulling on the root, right? No, gentlemen, this is not the root. This is a band of the PLL that is coming from below the axilla. That my cutter is not even able to cut through, but it is holding on to. And then I finally cut, clean, and you can see the root. You can see the axilla. And you can see the dural rent over here. The rent in the annulus over here, small. And now finally doing the decompression, a little extra phlebectomy to create a little extra space to make sure that everything is fine. So PLL pathologies should never be ignored. PLL is a very important part of a spine surgeon's success. We had put up a quiz, and I'm going to play that quiz as the last part of this talk. I thank you for your patience and kindness to be with me today. So what was our quiz? Oh, sorry. We go to the first slide and we say, what will you do? Gentlemen, see this.
Let me show the video for me.
Sure.
I got the final second.
Yeah. Please go ahead.
Yeah.
I will stop. You can show.
Okay.
I'll stop sharing my screen and you can show yours. Please share your.
Thank you very much, Dr. Pestonji, for this amazing and informative lecture. Now we will move forward with our giveaway session. Professor Hasan Kamil Sucu will share a very short video. Then we will ask a question about this video. Dr. Malcolm Pestonji will sign his book and give it to the first person to answer the question correctly. So now Dr. Hasan will take over. Thank you.
Can you see the video? No?
Yes.
Okay. I will show the video and then I will give the link for question and answers. If you answer first time, you will take
Good morning.
Present.
Sometimes we come across a situation where we need to decide, how will I treat a patient? What will I do? It's important at such times to see things carefully. See this patient. There is a marginal foraminal stenosis at 4-5, slight anterolisthesis. If you were to see the axials, I don't know whether you would decide on surgery itself. You would most probably give this patient some gabapentin, some analgesics, but this patient has been having this problem for the past 3 years. He has taken multiple root blocks. He has taken multiple epidural cortical steroids. No relief in his symptoms. And now, I decided to investigate him further. See what the CT scan shows. It shows something very shocking. At 4-5, we have severe foraminal stenosis. Severe. We have a posterior claw coming and a disc bulge. We have ossification in the flavum. We have a marginally upriding SAP. And the neurology of the patient has been explained to you. He's 79 years old. He's not keen on any form of fusion surgery. But obviously the option open to a normal person would be to consider a TLIF, the removal of the large hypertrophic right facet, severe collapse of lamina, interlaminar space is less, so you would consider a TLIF most probably. The CT scan also confirms the calcification in the flavum. You can see the arrow over here. And you can see the marginal listhesis over here and a claw formation behind over here in the X-ray. Let us view the next slide. There are 3 cuts from the upper, middle, and lower foramen. You can see the calcification in the flavum. You can see a hypertrophied facet. You can see the elevation of the disc, the calcification in the disc. And you can also see the lateral recess stenosis in the lower cuts, along with ossification in the flavum. Now, what are the contributory factors in foraminal stenosis that I identify? I identify that the anterior factor is the disc protrusion, a disc calcification, a degenerative grade listhesis of one. Posterior factors are the marginal invagination of the SAP secondary to a collapse, clumps of ossification within the flavum, and a flaval cyst.
Okay. Now,
I think the question
I
opened
will
with the
paste the link here in the chat box
what?
and can answer using this link. Okay.
Yes, so now we will move to the questions in the chat. Maybe Efe, you have a question to start with?
Yeah, I have a question, sir. Thank you for informative and didactic lesson, as always. And I want to ask, it's stated that UB is contraindicated in infections, uncontrolled infections and tumors. Have you used it in these cases?
To be very honest, in tumors, no. And in infection or in spondylodiscitis, unless you go in and unless you really clean up the mess and the pathology and try and get a biopsy sample and a pus sample, you're really never going to be able to treat it. So I agree with you that one must use covering broad spectrum general antibiotics for a day or two prior to surgery. That is the best approach. But beyond that, it is the identification of the organism and then the specific antibiotic therapy that plays the role. Now, it's a two-edged sword. The more you wait in infective spondylodiscitis, I'm not using the word tuberculosis. Please, tuberculosis is a lot in India and it takes a totally different trend, and I don't want to go into that right now. But in infection, patient is crying in pain, severe pain.
Yeah.
Dealing with the surgery doesn't serve a purpose because you're destroying more bone in the time. So a day or two, yes, pain control, trying to give broad spectrum antibiotics, and then entering there, cleaning up the whole mess and carrying out a fusion. I prefer not to put in bone graft. I prefer not to put in a titanium cage. I prefer to use a PEEK cage because it has minimal tissue body fluid reaction, and fuse the patient up, try and get an immediate culture report as soon as possible, and then start specific antibiotic therapy. Usually these patients do well. 90% of their pain disappears immediate post-operative period because you're washing away the EP substances, pain substances, the muck, everything. You're freeing the neural elements, adding an element of decompression if it was not done in the previous surgery, because you may have just done a micro-targeted discectomy. But this time when you go around, I prefer to do a proper phlebectomy, proper decompression, creating more space for the neural elements, putting in a drain. So these are the advantages. Yes, it has to be done, and so it has to be done. Regarding tumors, believe me, I don't have much experience, but two reasons. One is I'm from the orthopedic background, so I'm not licensed to enter inside the cord. So that's a field or a forte basically for neurosurgeons, but there are a lot of neurosurgeons like Dr. V. Zhang and Dr. Park and so many other people who has been started to do ependymomas and other extramedullary tumors with UB and using titanium clips to repair or close down the dura with using other, patches and whatever to just control the CSF leak. But they've been using it with UB, but at that time, I believe you drop the fluid pressure significantly because you don't want too much fluid building up in the brain. So that remains the problem. And that time you use a reverse Trendelenburg, high reverse Trendelenburg position to make sure the fluid doesn't really float up to the brain. But it's being done. So that is the next challenge in UB. Unfortunately, I'm not part of that because I'm really not licensed to do it. So I'll be humble enough to accept that I can't answer you on that.
Thank you, sir.
Okay, Nino.
Nino.
There are some questions.
Yeah,
I can.
read.
So one of the questions for
No,
plasma.
sir. Nino will read it for you.
So Dr. Hassan here asked you, are plasma generators and RF generators the same thing? What is the energy used when we say plasma? What is the frequency and wavelength of the energy used? And finally, what actually changes when we switch between ablation and coagulation modes?
Yes. Now, what is basically plasma? Plasma is a field of energy that is created when you cap a bipolar current. It is the same current. There are only two currents in the world. One is a monopolar and a bipolar current. There's no new current in this world. But when that current is delivered in a raw form, we say it's an RF generator. And an RF generator, for safety purposes, uses a 400 megahertz cycle. So that you use it in monoportal, you use it in transforaminal surgeries. While in plasma, we have a plasma cap. A ceramic cap is set on a tungsten wire so that when it generates heat and when you fire the plasma, if you've seen my videos carefully, you'll see a blue circle developing around the tip of the probe. And it is that blue circle, that energy field, which is the plasma energy field. So the plasma energy does what? It causes a dissociation of the ion of HNOH. And it causes the cell to rapidly enlarge and lyse. So therefore, it causes a volumetric loss of tissue, which an RF generator cannot cause. So it's just the same current, it's the same dish, but it's served in a different manner. That's all. The fact that what changes between ablation and coagulation modes is that the current frequency changes. Because the current frequency changes, the heat generation drops. And in a coagulation mode, the OH ion splitting volumetrically is higher, so you get more bubbling-ish effect. When you are firing in the coagulation mode, you will find massive amount of bubbling. When you're firing in the ablation mode, the current is more rawly delivered. Therefore, in these probes, you have two exposed wires also. So when you're using it in the ablation mode, the current is passing through the exposed wires. When you're using it in the coagulation mode, it is passing through the ceramic cap. And that is how the current switches. And that is why you are able to do tissue disappearance, tissue thinning, tissue cutting. And you can control the power that you give to the generator. So because you step down the power, you step down the coagulation heat. Human protein denatures at 70 degrees, but it undergoes an irrevocable change after 45 degrees of heat. So even 45 degrees of heat is enough to damage the human tissue in a permanent manner. That is why we use, when we are in the coagulation mode and we are very close to the neural tissues, we are actually walking on the neural tissues, we use it at its lowest, most power setting of 1 or 2. This brings down the energy so low that you can walk on the root will not even twitch. But the coagulation will be very slow. So you need to go to the vessel, sit on it, wait for the slow coagulation to occur. So that is the difference between an RF generator and a plasma generator. I will not go into more current specifics because that will require a major explanation. I will put it up on this group later on if you so desire, and you can spread it across. But in short, today it's late in the night. This is more than enough.
Thank you very much. Now the next question is from Yunus. He's saying, congratulations, and I have short question. Don't you remove LF bilaterally?
Depends on what you want to do. If I want to do a decompression, obviously I have to remove the ligamentum flavum not only bilaterally, I have to remove it from the foramens also. I have to see both the traversing roots and both the exiting roots. So you have to remove the ligamentum flavum is literally like a chicken without a head. It has extensions going out in the foramens. and you need to decompress all that, including the lateral recesses, right till the floor bilaterally. We must understand one thing, that the ligamentum flavum is a thicker tissue. And your dura, when it expands, is a very gentle tissue. It cannot push away a thickened ligamentum flavum. If you are not going to remove the ligamentum flavum in the lateral recesses right till the floor, your neural tube is not going to expand. You have only done a top release. If you see this patient's MRI with only a top release after 8 months, you will literally see an hourglass kind of a neural tube. And that's a shame because you have not removed the lateral flavums. So if you want to see a nice circular expanded cord, you have to remove the flavum from the lateral recesses completely. So it's a bilateral job. But if I'm doing a discectomy, now I've got a down migrated large herniation on the left side. For example, why should I even go to the axilla? I will go to the junction of the upper edge of the lower lamina and the facet, that is the SAP. I will go to that corner, just do a marginal flavectomy there and remove my fragment. So all depends on what is the indication and what you're planning to do for that. Next question, please.
Thank you. As I see, you don't use any vertebral spreader when performing cage insertion in the cervical region. If so, isn't it hard to
Yes,
put the cage within the intervertebral space?
Yes, it is hard. But there is a question of judgment. If you know that your cage is, you're going to use a 7mm cage, then I know with my instruments, like supposing I'm using a flexi tip burr, then I know that my burr is going to give me a 4mm corridor. So I know that I've already created a 4mm corridor. If I burr maybe 2 millimeters on each side, I will have reached 6mm corridor. I can easily put in a 7mm cage. So yes, a certain level of technical finesse and calculation, or if there are certain instruments that tell you the size. Now I have a 90-degree ball tip hook which starts from 2mm, 2.5mm, 3mm, 3.5mm, up to 6mm. I have all of them in my set. I just need to put in a right angle hook inside and it tells me the size. Yes, Malcolm, the size is 5mm. So I know, okay, now I've created a 5mm trough. I have to put in the cage. What I do is I do another trick, which is an intelligent question, so I'll answer that. One is the neck has to be slightly extended. And I use a normal, I don't know, we normally, physiotherapists, they give a traction belt. So what I do is I take a traction belt and I tape it up from front and back. And I just tape up all the belt up here on the head, so it doesn't shift. Now this traction belt is, I ask the anesthetist at the time of putting the cage to give me a gentle traction. So he gives me a gentle traction. I'm easily able to put my cage there and then gently tap it in. I don't want it going in very easily. I want it going in hard. I want to struggle putting in my cage. That way I'm sure that my cage is a good fit, that it will not migrate. And I try, initially I was very aggressive. I used to cut the posterior osteophyte excessively. Now I just cut exactly in line with the vertebral body. If you notice the videos carefully, you will realize that I have not overcut the posterior vertebral osteophytes. I don't want a posterior migration of the cage. So that is why nowadays I use the locking cage. So the screw makes sure that the cage does not migrate posteriorly. Initially, we used to use only peak cages, standalone cages without fixation. So we used to have a little uncomfortable patient. I used to be a little worried, especially if I've done a lot of posterior osteophytectomy. But now that is not the case.
All right.
Next.
Thank you very much. Jihan Kirchil would like to ask you how to be secured enough outflow of saline during UBE. What is the most safe way to be sure for the outflow with no need to check frequently during surgery?
See, I tell you one thing, when I start my surgery, I mentioned this point to you before. I put in my tubes and I don't remove my tubes. The instrument portal is the portal which you use serial dilators. It's a larger portal. The cut in the skin is only 5 or 6 mm, but you're using a tube of up to 10, 11, or even 13 mm to dilate. Now, when I keep the tube inside there for 5 minutes and I'm preparing the other portal, I'm connecting, checking my scope, the white balance, and the fitting of the guard and things like that, I am spending time doing something constructively, but at the same time, these pipes are acting like a tamponade. Not only are they acting like a tamponade to stop the bleeding, but they are actually forming the port. So after 5 minutes, when I start the fluid, I develop pressure in the system, and then I pull out my pipes. When I pull out my pipes, a small clot will gush out, and then clear fluid will start pouring out on the patient's back. After that, if you're still not sure, you can use a semi-tubular retractor, the retractors which I showed you in the set. You can use that, or you can use in a small, you get half-cut cannulas also. So when you're doing your initial UB little, and you're not confident of your ports, you can use those half-cut cannulas as a safety to make sure that you have good fluid flowing out in the back of the patient. So you have two options. Nowadays, I'm beyond that. I don't need that. I'm so confident of my work. But I would definitely recommend a young student starting his first few UB cases to use the semi-cut, half-cut cannulas. So that way you make sure that your egress portals are open. Many surgeons, they also use like shoulder arthroscopic cannulas. But I don't like them for two reasons. One, if a piece breaks, you will not be able to identify where that piece is broken and gone in the body. If you use a burr, you may grind plastic into the human body. And third, again, it's a restrictive portal. The whole advantage of UB is I can put a scope here, I can work like this. I can work like this, I can work like this. So why should I again introduce a port which restricts my movement? So that is why I generally don't teach my students to use these ports. I prefer to use the semi-cut cannulas for students. And eventually, as your practice grows and you become confident, you don't need it. Next question, ma'am.
Mr. Murat would like to ask, why is anterior endoscopy necessary for cervical disc herniation? No muscle damage is done with microsurgery.
Neither is it done with endoscopy. It's just that if I can put in a 4 millimeter endoscope, go right till the fragment and just pluck it out without doing anything, without causing any damage to the rest of the disc, because I'm bypassing the rest of the normal disc, going right till the fragment, I think it is better than an anterior microsurgery, because in microsurgery, you are going to remove more discal material than you would with a scope. So therefore, a scope is much advantageous, because if this is where the fragment has come out. Let us say this is my fragment here. My scope comes right till here. It comes right till here. It comes out here. Puts the fragment in. But when I am doing a microscopic endoscopic surgery, I may not be doing any muscle damage, but I need to dig into the damage to reach the fragment behind, no, which is in the canal. Here, I'm just dilating my path with my dilators and directly reaching the fragment. So which is a better option? And I am also not touching the muscles, neither are you touching the muscles. But I told you something in the beginning of the topic. Before we spoke of consensus. We spoke of doing what suits you best. If you are comfortable with your results, I have no comments on it. But if you ask me why I would prefer an endoscope, definitely I'm reaching at the root of the fragment. Bypassing the entire normal disc, I'm just taking a 4 millimeter track in a disc which is 17 millimeters across. So I am preserving the rest of the discal material, which even in a microscopic setting, you are going to remove definitely more of the anterior discal material. So that is the core difference. Next question, madam.
All right, thank you. How much SAP would be resected without disturbing stability? Is there any landmark to be stopped further resection?
Yeah. Now, two intelligent parts in this question. How much of the SAP should be resected without disturbing stability? Less than 50%, standard, proven, articles. by everyone. So that is not an issue. Now the question is of the landmark. How do I know how much am I removing? For that, I have to rely on the CM. I have to rely on my preoperative CT. I have to, in the coronal section of the preoperative CT, you can actually measure the length of the superior articular process. And you can pre-decide that I want to cut, let us say, only 4 millimeters. So then I will put in a 90-degree ball tip hook of 4 millimeters from the tip, mark it with my osteotome, and just knock off that much part. So the preoperative CT coronal image at the pedicular level will show you the length of the SAP. You can actually measure and cut exactly what you wished. That's how it is to be done. But
Mr. Jenner Erken would like to ask, do you use 30-degree scope for Para-UBE and switching portal technique?
Yes, it is. You have to use that because this is the facet and you are seeing the facet from below upwards. So 0-degree scope will not allow you to see to the roof. If you want to see the roof, you have to either look up or you have to have a scope that will show you up. If I have a mirror that shows me the roof, I can operate. So therefore, a 30-degree scope is a must in Para-UBE and in ipsilateral cutting, even in ICLF, because you want to see down and into the opposite foramen. So therefore, these are the indications for a 30-degree scope. That's why we spoke initially the advantage of learning with a 30-degree scope, because switching of your mental acuity between images of 0-degree and 30-degree every time is a nuisance. So I teach my children to learn 30-degree. I understand that the opposite side is going to appear a little flat, so you can partially rotate the camera head towards the cranial side. So it will show you the entire arch of the lamina. It will show you the arch of the curving of the facet, and you can determine how deep you are going. So 30-degree is what I prefer. Again, it's individual.
Thank you. And the final question. When you say 60 degrees, is the hook narrow angled or wide angled? It looked like wide angled in the video.
It's 120 degrees, right? It's 120 degree. I call it 60 because 90 and I call this as 60. It's the reverse way to count it. Yes, it's a wide angled hook because what happens is, supposing this is my, okay, I'll just put it this way. I'll show you with my hand. Now, if this is 90 degree, this can only go here and it won't go further deeper. But moment it becomes 60 degree, it can go till here. So the 60 degree allows me to slide deeper and clean better. 90 degree will restrict me here. So this is the difference between 60 and 90. So therefore, in your armamentarium in UB, you need a 60 degree hook because there is a bone shelf here. And now I want to sweep here. So if I'm using a 90, then I will not reach here only. I will have to use a bigger and bigger hook, and it then becomes difficult to introduce such hooks. A 60 degree hook at the same time will allow me to engage here. So it allows me to go deep. That is the advantage. But I call it 60, but it's a 120 degree. I agree with what he says. I should correct myself. Thank you.
Thank you, Dr. Pestonji. This is it for the questions. Now I would like to give the platform to Dr. Hassan so that he can tell us who's the winner. So
we have
giving the
3 people who answered the question. One of them is, let me see, Murat Kiraz, and the other RKL from India, but he didn't write the correct name, RKL. And the third one is Madonna Akobatse from Georgia. And the first, by the way, all of them answered correctly to the question, which is unilateral biportal endoscopy with foraminal decompression, which means without any fusion surgery. And the first one is Murat Kiraz. to who answered correctly. If he is here, please turn on your microphone and camera so we can see you. Okay, and I will. Okay, you can turn on your microphone also. Okay, congratulations. Dr. Pestonji, can you sign the book right now if it's with you?
Yes, definitely kept it here.
Please write a message and sign it.
I will.
Dr. Murat,
I
can
will.
you write
I
your
will need a speaker too. Dr. Murad, correct?
Yes.
Murat Kiraz? Yeah, I think we can. Sure, we can write there here. I send it to you, the correct name in the chat part.
Yes.
Murat Kiraz, right? Correct. Okay. Thank you so much.
Thank you.
It's on its
Dr.
way to-
Kiraz, write your email address, please, to me.
Okay.
I have to
On
hear
the
it.
chat part, Dr. Malcolm Pestonji will send you the book.
You should receive it in 4-5 days. But now, before we just wind up, let me share my screen once again.
Okay.
And let us just complete this. What will I do? So, what you can see here is the playing of the video. You can see the flaval separation zone developing here. Can you see the flavum separating from the lamina? So that is the cranial end I have reached. This is my facet on my side. Now I'm doing a flavectomy on my side.
Sorry,
And
we
a-
can't see your screen.
Have I not shared my screen?
No,
We cannot see your screen.
we cannot
Just
see your screen.
1 minute, so 1 minute. How can that be? Where am I? Can you see my screen now?
Yes.
Thank you. So I will just play this video. You can see how the flaval separation zone develops. This is burring underneath the lamina and slowly the flavum is separating out. This is my facet, my side of the facet. Now I'm doing a flavectomy on both sides. This is the midline. I'm cutting flavum on my side and on the opposite side. So I'm carrying out a proper decompression first. I'm doing a little more burring on an open dura. I'm going underneath. I'm cutting on the IAP SAP shelf, exposing, yes, that is the SAP. And now I've switched over and I've come underneath. I've done ipsilateral. So this is the opposite side, opposite lateral recess. I'm gone into the opposite lateral recess. And now I've come on my own side. And now I'm on my own side and I'm undercutting this ipsilateral side. Now I've gone on the opposite side and I'm cutting into my foramen, and you can see this calcified piece of flavum that is adherent to the dura below. Slowly teasing it with the kerosene, trying to bite it, but it cuts through. See, it's calcified bone, cartilage, calcium in it, in the flavum, which you are seeing on the CT scan. You can see the traversing root below. Now I'm able to grab it even better. And I pull out that whole calcified bit, but there is still some more left. Now I'm cutting this calcified piece of tissue here. Can you see that? Can you see how I'm mobilizing it from over the root? It's stuck to the transverse exiting nerve root. You can see the vein on the dura. It's pulsating and coming in my way. That is the amount of magnification you get. Now move that piece of calcified flavum onto the cord. Inside, I pulled it into the canal. There are two pieces there. So slowly, the first piece came out, now the second, then the third. So one by one, grabbing out all those calcified bits that were sitting on the root, exiting nerve root. Now opening up the IAP. So the exiting nerve root is becoming more and more free. But it is still locked by the claw below from the disc. So that's half the job done. So slowly cutting into the foramen and opening up the whole foramen, making sure first that the dorsal roof is opened up. You can see the discal surface below. You can see the disc over there below. Field gets a little bloody, you need to control the bleeding. Now that is a disc which I'm burning. That is the disc, the herniated disc, which I'm using plasma to ablate away. See the fragment over there. And as I burn it away, you can see the calcified edge. Can you see this calcified edge coming in your view? That was the claw from the disc, discal surface claw. The root is still above. This is the vein. When we spoke of Para-UBE, I told you that the root will be proximal by 2-3 millimeters to the vein. So I'm quite safe. I'm burning away the nuclear material which is coming up, retaining as much of annular fibers as possible. Now I'm in the axilla. Again, I'm on my side now. I've switched to my side. And I have to cut this claw from below the center, from below the dura. So I have to push the axilla, find this claw, break it, and burn it away. See, you can see the axilla nicely. You can see the claw developing nicely. That is locking the root. So now we are cutting into this claw slowly. See how the calcified chunks are coming out. So this is the hard disc part which you are cutting out. Slowly I am removing all that muck now. And now I'm using an osteotome to break whatever is the claw underneath the exiting root. You can see the exiting root here. But I'm still not happy. I'm going out into the foramen to break this claw. So first I broke from underneath the axilla and underneath the central cord. Now I've broken down from outside, removing some more, clearing up all the tissues. Now I'm using a spatula to break the rest of this claw from below the root. Can you see that? It's banging into that piece of bone, which has elevated and locked the root. So I have to break this completely. See how it breaks. So now I have to clear up this muck which I've created. That one piece came out. Can you see this piece here floating up? Now I'm using again that same 120-degree hook. I was calling it 60. It's 120. And now I'm pulling that piece out, which we had broken and pushed below the nerve root. That piece has to come out, which I have broken. Otherwise, I'm in trouble. So take some patience. And slowly that piece comes out. Now, after that piece is removed, you will see something very beautiful. Can you see the fat on the nerve root? So after that fragment is out, the whole nerve root has shifted down. Can you see this fat? You are
Yes.
not able to see this fat in the previous part of the surgery. So this nerve root has changed its angle because this bony whole piece is gone from here. We did some more cleaning and clearing up, but that's the end of it. So the phlebectomy, the opening up of the foramen, the cutting of the claw, making sure that the root becomes free and comes down, that is the end point of this surgery. And you have preserved functionality. In an elderly man of 80 years of age, you have not pushed him through fusion, osteoporosis, implant failure, infection, a million other problems that can arise with fusion surgeries. I hope you enjoyed this video. Thank you so much.